Oh, sorry. Hello, good afternoon, everyone, and thank you for the opportunity and the honor to be presenting in front of you this afternoon. So I'm tasked to present the state of stroke thrombectomy in the Philippines, current practices and challenges. Okay, these are my disclosures for this afternoon's talk. For a quick outline of this presentation, I'll go over the introduction, present to you the Philippine healthcare situation, address certain points about service delivery and utilization, and finally, I will show or illustrate the current practice by two representative cases. For an introduction, stroke remains the leading cause of disability and death in the Philippines, as with many other countries. And evaluating the current state of stroke care and looking at the needed resources and gaps in health policies is crucial to decrease stroke-related mortality and morbidity. Despite mechanical thrombectomy being very effective, the rate of utilization remains low at 0.4% of acute ischemic stroke, mostly because of the high associated cost. So with limited resources, there's a call for infrastructure and emergency medical services. There are certain innovations in neighboring countries, like we have seen here in Vietnam, that are very worth emulating for us. As we take a mirror of the low to medium level income countries, which have a similar situation to our country. So the use of technology to reach out to geographically isolated areas and mobile stroke units is an example. So as we probably all know, mechanical thrombectomy is a very effective treatment with one of the lowest number needed to treat. And yet there's a service delivery gap. We are not able to achieve this. Why is that so? So allow me to show you the Philippine situation. Our country is an archipelagic nation composed of more than 7,100 islands. And from 2009 to 2019, stroke was the second leading cause of death and one of the top 5 leading causes of disability in the Philippines. However, the true prevalence of stroke is uncertain because of poor data reporting. Add to that the problem of geographic isolation and disadvantaged areas, which have poor or limited access to health facilities, making effective delivery of health services very difficult. So there has been some promise in the form of a recently enacted administrative order by the Philippine government, namely the National Policy on Framework on Prevention, Control, and Management of Acute Stroke. However, this is still lacking in implementation. The other major problem is the poor or the limited reimbursement system by the government's national health insurance system. So as an example, for ischemic stroke, only 28,000 pesos is reimbursed. So compare that with the with the cost of mechanical thrombectomy, which can almost reach 1 million pesos if you add the hospital stay and all the other costs to it. So that having been said, more than 70% of healthcare expenditure remains to be out of pocket. So what are some of the gaps in stroke system care? So these are some of the reported gaps. There's a low number of neurologists as well as interventional neurologists and neurosurgeons. There's an inadequate number and availability of CT and MRI. Lack of stroke training, highly variable stroke protocols and pathways, mostly because this is very resource dependent. There is poor community stroke awareness, low government insurance coverage, as I've shown you a while ago, and the lack of infrastructure for emergency medical services. There's also an inadequate acute stroke-ready hospitals, stroke units, and rehabilitation facilities. So a little more about the Philippine healthcare situation. This is the number of neurologists. There will be, so in average, there's one neurologist for 218,000 Filipinos. And how about the interventionists? There's about one interventional radiologist for 2.08 million population. This is a distribution of the interventional radiologists of us in the Philippines. Most of us have their practice in Metro Manila. So the scope of practice, 90% of us perform whole body IR. So it's a mixed practice. And actually only 10% of this number have a specialized training for neurointerventional procedures. And with the lack of dedicated neuro-IR training in the Philippines, our interventionists have to go abroad to do further training. So one of us has gone to Vietnam, Dr. Narcisse. Some have gone to Singapore, France, or Australia. So what about the role of CT scan and MRI as has been discussed in the early morning session? So because of the lack of MRI, most of stroke patients undergo a CT, which is more readily available. However, that is still a density of 1.09 per million population. Now, the other thing that has to be addressed is the lack of cath lab facilities. Currently, there are around 62 cath lab facilities scattered all over the Philippines, with most of it in the National Capital Region. Now a little more about thrombolytics and mechanical thrombectomy. Thrombolysis rate overall was low at 1.4%. However, through various stroke training and education in different areas of the country by our Stroke Society, thrombolysis rate has increased to 11%. Now, another factor that helped in the promotion of thrombolysis therapy was actually that the RTPA was partially subsidized by the government for some time, leading more government hospitals to use thrombolysis. With the delayed access of care because of lack of stroke protocols, poor community stroke awareness, and lack of infrastructure, the problem is in the delayed ER admission for stroke. So most of them arrive well beyond 4.5 hours, the time period for IV thrombolytics. And as seen here in this chart, a very small number of them will have eventual endovascular therapy or combined IV thrombolysis with endovascular therapy. The Philippines, together with other neighboring countries, has one of the countries with a limited access to endovascular and IV thrombolysis, despite having a high stroke burden. So some of the additional causes are the following below. I would also like to emphasize the outdated practice patterns. So these kinds of trainings are very important, and the variability of interventional training. So there are limited hands-on fellowship trainings, and then there are some that have observerships. How about the thrombectomy experience in our country? So this is one of the studies that came out recently. In this particular case, most of the patients actually received stent retriever, and a smaller number have received aspiration thrombectomy. So these results are actually quite comparable in outcomes with other published data in the region. So I would like to focus now a little on the glimpse of the future. I think there's still hope after all. So improving stroke care in the Philippines requires a multi-pronged approach. So we have heard a little bit about the recognition of centers and quality stroke care by the WSO Angels program, as has been established here in this country. And I think what we are doing right now here, regular education and training of healthcare workers, is very important to form a consistent brain attack team. and also standardizing stroke pathways and protocols. So one of the innovations being done is an emergency radiology program at the Southern Philippines Medical Center. So it is the emergency room, the emergency radiologists, as well as the interventional radiologist working hand in hand in providing acute stroke care. So this assures the presence of a diagnostic and interventional radiologist in virtually all emergency cases. So teleradiology can help, rapid management and decision-making through Viber or some similar messaging service, and just to facilitate close communication between the various specialists involved. So some of the other initiatives was the inclusion of cath lab in all provincial hospitals. The Stroke Society has led by training of general physicians and establishing mobile stroke units to the far-flung areas. Our own society is in the works of establishing organ system-based subspecialty training, linkages with training centers and industry partners. So that's why these courses are very important. This is way back in 2019. Now, quickly, just some of the cases. A very young patient, GCS 15, has a left-sided weakness. For this particular case, a balloon guide catheter with stent retriever technique was used. So the patient presented at 11 a.m. and 3.5 hours later, the patient had a non-contrast CT which was normal. So RTPA was given, and the NIH S.S stroke scale, rather, was 0 at this time. So this is the imaging. So despite of the IV thrombolysis given, we see a core infarct here in the posterior limb of the internal capsule, and this cut off in the M1 segment of the middle cerebral artery. So now the NIH stroke scale went up to 10, and patient again had the left-sided weakness. So non-contrast CT was again done. It's relatively showed a stable infarct. And the decision was done to do mechanical thrombectomy. Here again, the cutoff, suggestive of the thrombus here in the M1 segment. And I'm not sure if you can see it here, the stent retriever was deployed. And well, the balloon guide catheter is not seen very well in this particular picture. I would like to acknowledge, by the way, the help of the interventional neuroradiologists who have kindly presented the following cases. So after thrombectomy, there was a reperfusion of the M1 and the other branches. So for this particular approach, Trevo stent retriever was used together with the XT27 microcatheter and flow gate balloon guide catheter. So one pass was done, achieving a TK2C. So subsequently, NIH stroke scale went again down. Patient just had a left arm drift. Okay, so another case, this time with right-sided paresis and aphasia. We have mentioned the intimate relation to heart disease. So in this particular patient, a direct aspiration first pass technique was employed by our group in the Philippine Heart Center. So this is the sample setup which they used. So there are several competing brands that can be used. I just want to show you an example of the particular setup. Okay. So the initial CT scan again showed a complete occlusion on the left proximal M1 segment due to acute thrombus formation with resultant decreased flow in the M1, M2, and 3 and 4 segments. So this is the angiogram. So let's see if it plays again. Yeah, okay, you will appreciate the cutoff here. And on the initial left internal carotid injection. So as mentioned, manual aspiration thrombectomy was done for this particular case. After one pass, TK3 score was achieved with complete reperfusion. So actually that already ends my short presentation, and I would like to acknowledge the help of our society, the Philippine Society of Vascular Interventional Radiologists, and the various interventional radiologists and interventional neuroradiologists who have been instrumental in this presentation. Thank you very much.
Thank you very